Transrectal ultrasound-guided biopsy of the prostate offers high sensitivity and is of low risk, but it can cause substantial discomfort depending on the number of courses taken, requiring systemic analgesics. We developed a new method of fine needle administered local anesthesia to the prostate, eliminating biopsy-associated pain. Besides the commonly required material for the biopsy procedure, we additionally need a 26-gauge, 25 cm fine needle and 20 milliliters of a local 1% anesthetic. Mucosal anesthesia of the rectum is achieved by application of the lidocaine gel Instilogel delivered in 6 milliliter syringes. As a first step of the procedure, 6 milliliter Instilogel is injected into the rectum before preparing the ultrasound probe. We use a side-firing needle guidance from Toshiba for the injection of local anesthetic and controlling the biopsy needle. Using a side-firing guidance, the patient is comfortably positioned on his left side. For performing the anesthesia, 10 milliliters of 1% ultracaine local anesthetic are injected posterior-laterally in the region of the neurovascular bundles on both sides of the prostate under truss control. For injection of the anesthetic, a 26-gauge fine needle is used. Under ultrasound control, the application of the anesthetic is directed to the posterior lateral aspect of the prostate on both sides. The exact position of the needle tip is easy to determine. After having allowed the anesthetic to unfold its effect on pain sensation, the routine 10-core truss-guided prostate biopsy procedure is started. 5 biopsy cores with a true-cut needle launched by the biopsy gun are taken from each lobe of the prostate. Again, transrectal ultrasound control offers high precision in directing the needle to the peripheral zone of the prostate in both lobes. Even the needle advancing with high velocity into the prostate is displayed in real time. In this special case of a repeat biopsy of a large prostate, an additional transition zone biopsy core was taken from each lobe. The efficacy of our method was evaluated in a prospective randomised trial of 108 consecutive patients. A total of 68 patients without previous biopsies were randomized in receiving fine needle applied local anesthesia or not. A third group was constructed for patients receiving a repeat biopsy. Here, all patients underwent the local anesthesia procedure. In Group 1 without local anesthesia, average pain documented by a visual analog pain score was 3.29 as compared to an average score of 1.85 in the local anesthesia Group 2. This difference was statistically highly significant. In group 3 of patients with repeat biopsies, all performed with local anesthesia nerve block, the average pain documented was as low as 1.71 in comparison to the previous biopsy done without local anesthesia, resulting in an average score of 4.59. This difference was also statistically highly significant. We conclude that fine needle applied local anesthesia to the prostate prior to TRUS multicore biopsy significantly reduces pain independent of the number of cores taken, has low additional costs, but is of high benefit and does not lead to a higher complication rate. This procedure has therefore become standard at our institution.